Hi, I'm Anne with Lighthouse Coding. Today we're going to work through a couple of practical application questions for Chapter 4. Let's start with case number 1. We're going to be looking at a progress note and picking out the correct diagnosis code. The patient is a 50-year-old female who began developing bleeding and bright red blood per rectum approximately 2 weeks ago. She is referred by her family physician. She states that after a bowel movement, she noticed blood in the toilet. She denied any prior history of bleeding or pain with defecation. She states that she's had an external hemorrhoid that did bleed at times, but that is not where the bleeding is coming from. She's presently concerned because a close friend of hers was recently diagnosed with rectal carcinoma requiring chemotherapy, and that was missed by her primary doctor. She's here today for evaluation for a colonoscopy. On physical examination, she appears to be a well-appearing 50-year-old white female. Abdomen is soft, non-tender, non-distended. Plan: we'll schedule the patient for an outpatient colonoscopy. The patient was made aware of all of the risks involved with the procedure and was willing to proceed. What diagnosis code or codes are reported? So this patient is presenting with rectal bleeding. That is the main complaint. During the encounter, the patient stated that she's had a hemorrhoid in the past, and the assessment stated that this is a 50-year-old female with rectal bleeding. Since rectal bleeding is the assessment, that is what will get coded. Although the patient did report a history of a hemorrhoid, this was only a patient-reported condition. There was no documentation of it in the exam or the assessment, so it will not get coded. To find the code for rectal bleeding in the alphabetic index, we'll look up the term bleeding. From there, we will scan the subterms until we find rectal, and we're referred to case 62.5. When we look that up in the tabular list, we see that case 62.5 is indeed the code for rectal bleeding. Now let's look at case number 7. This one is a bit more complex. This is a follow-up visit. The patient has had some memory problems. She's hard of hearing. She is legally blind. Her pharmacist and her family are very worried about her memory issues. She lives at home and her family takes care of laying out her medications and helping with the chores, but she does take care of her own home to the best of her ability. On exam, she's a pleasant 85-year-old woman in no acute distress. She has post-op changes of her eyes. TMs are dull, pharynx is clear, neck is supple without any adenopathy, lungs are clear with good air movement, heart is regular, she had a slight murmur, abdomen is soft, moderately obese, non-tender, extremities, no clubbing or edema, foot exam shows some bunion deformity, but otherwise healthy, light touch is preserved, there is no ankle edema or stasis change. Examination of the upper arms reveals good range of motion. There is significant pain in her shoulder with rotational movements, and it's localized mostly over the deltoid. There's no other deformity. There's also very slight left shoulder discomfort and slight right hip discomfort. Impression is dementia, right shoulder pain, benign hypertensive cardiovascular disease, a complication of diabetes, and type 2 diabetes with good control. Most recent A1C done today was 5.9%, liver test normal, cholesterol 199, and LDL a little high at 115. Plans: I offered her and her family neuropsychological evaluation to evaluate for dementia. Her system complex is consistent with dementia. Whether it be from cerebral small vessel disease or Alzheimer's is unknown. At this point, they would much rather initiate treatment than to go through an exhaustive neuropsychological test. For the shoulder, we decided on a right deltoid bursa steroid injection. She's had an injection for bursitis in the past and prefers to go this route. She'll ice and rest the shoulder after the injection and follow up in 3 months. And then the provider also documents the injection that was performed, and it says injection right deltoid bursa. The point of maximal tenderness was identified. Skin was prepped with alcohol. A 25 gauge, 1.5-inch needle was advanced to the posterolateral edge of the acromion and into the subacromial space and then aspirated. 1 cc of 0.25% Marcaine mixed with 80 milligrams depomedrol was deposited. Needle was withdrawn and Band-Aid was applied. Post-injection, she had marked improvement with increased range of motion consistent with good placement of the medication. She was started on serafilin plus NAC, and an Aricept starter pack was given with email away script. Follow up in 3 months, and we will assess her dementia at that time. What diagnosis code or codes are reported? The patient has multiple diagnoses. Under the impression, we have dementia, right shoulder pain, benign hypertensive cardiovascular disease, which is a complication of diabetes, and type 2 diabetes. It's important to report the diagnoses that the provider treated during the encounter and any chronic conditions that affect the care of the patient. The provider documents that the patient has dementia and they're not sure of the cause. If we look in the ICD-10 alphabetic index for dementia, it directs us to F03.90. We should scan the list of subterms to see if any apply, and in this case, they do not. The provider did not document any aggressive or violent behavior or any associated disease, so F03.90 is appropriate. We'll need to verify that in the tabular, and we can see that F0390 is the code for unspecified dementia without behavioral disturbance or dementia NOS. The provider also performed a joint injection to treat the right shoulder pain. In the alphabetic index, we'll look for pain and then shoulder, and that directs us to M25.51. We need to turn to that page in the tabular list to verify the 6th character. We can see that the 6th character is 1 for pain in the right shoulder, so M25.511 is the correct code. The patient is also diagnosed with benign hypertensive cardiovascular disease. The provider reviewed the labs, which were the cholesterol and the LDL, to monitor this condition. In the alphabetic index, we'll look for hypertension/hypertensive, and then cardiovascular disease, and it says to see hypertension heart. So we'll go to the term hypertension and then heart, and we're directed to I11.9. This is a combination code that includes both the hypertension and the heart disease. We can verify that in the tabular list, and we see that I11.9 is the correct code for hypertensive heart or cardiovascular disease. The last diagnosis listed is controlled type 2 diabetes. Whenever we're coding for diabetes, we need to stop and think about the possible manifestations. In this case, the patient had cardiovascular or circulatory problems, and those are documented to be a complication of the diabetes. In the alphabetic index, we'll look for diabetes type 2 with circulatory complication NEC, and that directs us to E1159. E1159 is reported because the physician documents that the hypertension and the heart disease are complications of the diabetes. Remember, the diabetes mellitus codes are combination codes that include the type of diabetes, the system affected, and the complications affecting that body system. We can verify E1159 in the tabular list, and we see that E1159 is the code for type 2 diabetes with other circulatory complications. Let's look at those diabetes codes in the index. We'll look under type 2 diabetes to see the many possible manifestations. I want you to notice something here. In the alphabetic index, under diabetes and then under type 2, we have an indentation with the term with, and then under with is a list of conditions. There is a guideline that describes what to do when we see the term with. The guideline says the word with or in should be interpreted to mean associated with or due to when it appears in a code title, in the alphabetic index, either under a main term or a subterm, or as an instructional note in the tabular list. The classification presumes a causal relationship between the two conditions linked by these terms in the alphabetic index or the tabular list. These conditions should be coded as related, even in the absence of provider documentation explicitly linking them, unless the condition or the documentation clearly states that the conditions are unrelated, or when another guideline exists that specifically requires a documented linkage between the two conditions. For conditions not specifically linked by these relational terms in the classification, or when a guideline requires that a linkage between the two conditions be explicitly documented, then provider documentation must link the conditions in order for them to be coded as related. In the practical application that we just worked through, the provider linked the hypertensive heart disease and the diabetes. In that case, using a combination code was pretty straightforward. But sometimes conditions will not be linked to diabetes by the provider. The assessment might simply say 1, diabetes mellitus type 2, and 2, chronic kidney disease. When you look in the alphabetic index under type 2 and then under the term with, you'll see the term chronic kidney disease listed, E1122. Since these terms were linked with the term with, the provider does not have to document a connection between the two conditions in order to use the combination code. The association is presumed. That's it for today. Thanks for watching, and I'll see you in the next lesson.